Great. So we are going to have a excellent next session addressing a variety of things related to the brain-gut axis, diet, food, and emotions. And our first speaker is Dr. Stephen Banner from Queen's University, who will be talking on the brain-gut microbiome axis, influence of diet and emotions.
Thank you very much. It's my pleasure to take the opportunity to highlight to you some of the recent advances in this area. These are my disclosures. And so I hope that as you listen to this presentation that you'll give some thought on how you might start to incorporate these concepts into our discussions with our patients, because I think it's important that we do so. So I want to just highlight, as I mentioned, the relationship between the microbiome, the diet, and the emotions that can underlie IBS symptoms. And I'm going to talk to you about some of the fundamental concepts and mechanisms that might be important. Some of these I think you find somewhat provocative, but very exciting and interesting. So just to begin and set the stage for this, as you know, one of the quandaries we have with our patients is that when we do a colonoscopy, it looks completely normal. And we know, however, though, that if we take a small pinch biopsy for research purposes, in fact, it's often not normal. And we know from several seminal studies that there's subtle but important increase in levels of inflammatory mediators, in particular histamine and proteases that presumably are coming from mast cells. And you can see on the right this close association between nerve terminals and mast cells. And we know that there's important signaling with sensitization of nerves and amplification of pain sensing in the gut because of this. So I'd like to propose to you that this relationship between our emotions, diet, and microbiome might be one of the explanations for why we're seeing this subtle evidence of inflammation in the gut. And a recurring theme is also going to be the notion that this is not a static relationship, but this is a dynamic process. And this concept may help us to understand some of the complexities that are challenging us in irritable bowel syndrome. So what I plan to do is touch on each of these three areas independently, and then at the end put it back together for you. So what about the microbiota? Well, there are a number of emerging themes that are coming out from numerous studies in this area. We know that the diversity of the microbial population has been found to be reduced in IBS. There's a proportion of specific bacterial groups that's altered. There's a degree of variability in the microbiome composition that's different in IBS in patients compared to healthy subjects. And there's a higher degree of temporal instability of the microbiota among IBS patients that's been detected. And I would also add just an additional caveat that we need to keep in mind that it may not actually be differences in the species, but it may be the differences in what communities are actually producing. We'll come back to that in a minute. So this is a complicated slide, and it's meant to be because this is a complicated picture. And this is data from a Rome review that was published a number of years ago, but I don't think the story's changed much. That when we look cross-sectionally at a population of IBS patients, depending on the study, we see varying results. And this just highlights in yellow that I know you probably can't see, but you can maybe see some arrows. Some are going up and some are going down, and the species are different. And we really don't have a clear picture of what the microbiota signature is in IBS patients. Now, it's likely that it depends on which subgroup of IBS patients that you look at. And this is just one example. This is a summary diagram from Maggie Simran's group, and showing that if you separate out patients who have psychologically dominant driven symptoms from those who don't, that you then start to see a little clearer picture of a common microbial signature. Well, what about diet? So there are a host of diets now being proposed for irritable bowel syndrome. And I don't have time to mention these, and Bill will talk in more detail about several of these. If you're interested, Caroline Tuck, who's a PhD dietitian, written a terrific review going into detail of all of these, talking about the evidence for them and what the purported mechanism might be. For the purposes of my talk, I want to focus on FODMAPs because they're a nice example of the interaction between the diet and the microbiome. Most of you will know that FODMAPs are these poorly absorbed carbohydrates that then escape down into the small intestine and colon. And in the colon, they're fermented by the microbiome. They produce gas that distends the bowel, but also other active metabolites. So I want to walk you through, just briefly, some studies that we've been doing that explore this in more detail. So these are the results from a study that we did where we randomized IBS patients to either a low FODMAP diet or a high FODMAP diet. And as you'll hear more about, and many have reported, we saw an improvement in symptoms over a 3-week period for the low FODMAP diet, but we saw either no change or often worsening of symptoms in the high FODMAP diet. And this shows that when we looked at pain, it was significantly reduced, and similarly, there was a trend with bloating. We were particularly interested in looking at the metabolome, and so we had the urines before and after on these patients, and we sent them off to the Metabolomics Center through Karen Madsen in Edmonton, Canada. And what we saw was, when you do a principal component analysis, you see this very interesting shift in the metabolome that's being driven by the diets in these patients. And so, of course, we were interested to know, well, what could be the active metabolite or metabolites that might be driving this. And much to our surprise, but interest, of course, was that histamine was one of the main drivers. And here you see in a subset of patients that on the low FODMAP diet, histamine is being reduced, and on the high FODMAP diet, it's actually going up in a number of patients. So we were interested then to know more about this diet microbiome interaction in these patients. So to do this, we used a reverse translational approach where we took the microbiome from the patients in the study and we introduced them into germ-free mice, so-called humanized mice now, and then studied the effect of the diets. And this was done at McMaster with a collaborator, Tim McPherson. So we took off the shelf, if you want, the microbiome from one patient where they had worse symptoms on the high FODMAP diet, and they had evidence of immune activation, i.e. high histamine. And we put that into the mice. A second patient had no change in symptoms on the high FODMAP diet and low histamine at entry, i.e. no evidence or little evidence of immune activation. And then there was a healthy volunteer who had no symptoms of irritable bowel syndrome. Now, the most important finding was that the diet, the high FODMAP diet, virtually had no impact on any of the markers, including visceral hypersensitivity in the healthy volunteer, whereas we found profound effects in the IBS patients. But the study went beyond that because what it showed is when we looked at these various markers, for example, permeability, mast cell numbers, tryptase levels, transit, stool histamine production that I'll come back to, and visceral hypersensitivity, we saw important differences even within the patient group. So this suggested to us that the microbiome was in fact playing an important role, at least in a subset of patients, but even within the patients, there was variability in the amplification that was causing in terms of producing these active metabolites. So let's move on now to our third parameter, and that's the emotions or psychological signaling. And you've heard many of these mechanisms before: the activation of the hypothalamic, pituitary, adrenal axis, and the adrenal nervous system, signaling to the gut, modulation by descending innervation, permeability changes, immune modulation, and also that this is, again, not just signaling to the gut, but this brain-gut axis signaling back to the brain. So I'm just going to highlight three areas that I think might be a sort of emerging, a bit provocative, but I think very interesting. And the first is that the notion that our emotions or psychological factors can actually shift the microbiome. There are actually these neurotransmitters, bioactive amines, are actually signaling to the microbiome. And this is just one example. This is a fluorophore that's taken up by the transporter in bacteria, in this case, Lactobacillus species. And you can see when noradrenaline is given that it competes for the same transporter and is being taken up by the bacteria. Now, what's particularly interesting is that it depends on which species of Lactobacillus you look at. So it's not having a global effect on the microbiome, but potentially affecting specific species. The next notion, which I think is particularly interesting, is the concept that certain parameters can lead to the loss of oral tolerance to food antigens. Now, normally we eat food and it doesn't induce an immunogenic response. But there are several studies now, been led by Guy Bockstans and also collaboration with David Reed's group in our group, showing that if you challenge a mouse with either post-infectious colitis, similar to E. coli infection in humans, it's self-limiting, or you stress the animal, you can break this tolerance and induce immune activation with activation of mast cells, sensitization of nerves, and really recapitulate what we're finding with this subtle inflammation in IBS patients. He has also shown in preliminary studies that if you take IBS patients and you inject antigens into the colon, you can get a local, not a systemic, but a local immune response with activation of mast cells. And this is not dissimilar to what's been more recently described in allergic rhinitis and some other disorders. And then there's also this notion of psychobiotic probiotics. And this is two examples from the McMaster group. On the left is shown the notion that you can take the microbiota from humans and change the psychological phenotype of mice. So here they've taken the stool from healthy individuals, from IBS patients and IBS patients with anxiety, and based on this readout in the mice, shown that they can induce an anxiety-like phenotype in the mice. And on the right, they've shown in a preliminary pilot study that the use of this probiotic can reduce depression in patients compared to placebo, and that they can get correlates in the functional MRI imaging. So I've given you these three different signaling pathways, And you can see that it creates a very complex dynamic, and it's further complicated by, of course, our conscious and biases about all of these factors. And indeed, this is something that's important in diet studies because, and what we see clinically, is what patients' perceptions are. And there's this new condition called orthorexia nervosa, where patients have this unhealthy notion that diet explains all of their GI symptoms, and they put themselves on these very restrictive and unhealthy diets. Now, I want to come back to this theme of this dynamic complexity that's going on, and just to highlight this further, show this graphically in a different way just again. So what I've shown here is these different pathogenic factors or signaling pathways that I've talked to you about, and what's happening over time. And what I want to show graphically is that if we look at the patient at this particular time, one or more of these factors may be dominant. But if we look at the patients at another point in time, we may not only see a shift in their symptoms, but we may see a shift in the particular emphasis on which of these pathogenic mechanisms might be important. So I'll end with this slide. So what do I tell my patients? Well, I tell my patients that there's growing evidence that the microbiota and microbiome is important in patients, that diet, beyond just the act of eating, which I think we told our patients for many years, it is likely important in terms of the pathogenic mechanism itself, whether it's the actual nutrients that are signaling to our bodies or through this diet-microbiome interaction, and that our emotions and psychological factors certainly can modulate and amplify these factors up and down. But our challenge is that we really don't know which patient and when in these patients these particular mechanisms may be important and help us to guide therapy. So we've got a lot to learn here. Thank you for your attention.
Our next speaker is Bethany Dorfler from Northwestern, and she will be speaking on heartburn.
Good afternoon, everyone. Thank you so much for inviting me, and thank you for having such a wonderful session on diet and lifestyle approaches. What we'd like to talk about today is give you an updated look at what we can do for our patients who suffer from reflux, from heartburn, whether they're responsive to PPIs or not. I want to walk you through some of the traditional dietary advice that patients have received and suggest some alternative ways to think about what advice we give to patients regarding diet. I'd also like to give you a few tips and tricks that you can use in your own practice. These are answers to these questions many of you have fielded, whether or not it's okay to take apple cider vinegar, try digestive enzymes, modify their diet. Some of you may feel like you have a separate degree in nutrition by the time you're done with your reflux or IBS clinics. Recent expert opinions published in ACG have suggested that for patients who have reflux and have symptoms persistent, should be addressed with diet and lifestyle, and that whether or not people respond to PPI, what I would like to suggest is that rather than thinking of diet as a way to substitute PPI, which we currently don't know to what degree we can do that. We have ongoing research at Northwestern looking at that, so stay tuned. But at this point, we like to think of diet and lifestyle as a power booster. Wouldn't it be wonderful if we could use lifestyle therapies to reduce PPI use or to get patients onto a lower dose, or to simply say that they feel better on the medications they're taking? So with that in mind, I'd like to just review what we've historically told people. Historically, patients, when they go online, might find advice about limiting acidic foods, carbonated foods, chocolate, peppermint, Because some of my patients will say, well, I can't really chew gum anymore because, I really can't have mint. And while some of that might individually trigger symptoms, what I would like to suggest is that that really needs to be largely individualized. We're now moving into a space where we're saying, if it doesn't bother you, there's no need to overly limit it, but let's look at modifying factors which are going to give you big symptom payout. When people look for advice on what to do with their diet, and if you have reflux, one of the most common recommendations your patients will hear is that you should lose weight. I'll show you some data in a few slides reminding you that even modest weight loss in normal weight patients seems to help reflux symptoms. But what you can see here is that patients are overwhelmed by the information that they're getting and oftentimes feel paralyzed to make changes because they simply don't know where to start. So let's take a look at lifestyle. And before I suggest some tips that you can use in your practice, it's important for us to get an updated look at what Americans are eating. And when we're looking at what we're eating, the other side of that coin is equally how Americans are eating. So just to remind you that weight loss independently improves GERD symptoms. And with more than 2/3 of our population struggling with overweight and obesity, we're not meeting our healthy lifestyle goals. Not that we have to be perfect, but we have to kind of move the pendulum to our patients' benefits. So I'd love to show this slide because this is food consumption data patterns from the 1970s to now. And what this shows us is that over the past several decades, Americans eat more than 600 calories more than we did in the 70s. And almost all of those extra calories come from extra saturated fat and refined carbohydrates. If we break that down further, we're eating more saturated fat than ever. Being from the deep dish town of Chicago, you can see that when this is broken down further, burgers and pizza are the major contributors of extra fat in the diet. Probably not great foods if you have reflux. When it comes to sugar, we're eating about 400 calories more of sugar than we used to in the 70s. And most of this comes from refined sugary drinks, but also foods like granola bars and bagels and pastries and so forth. You can also see that tiny little red sliver, 1%. That is the percentage of sugar calories that come from fruit. So we're certainly not overdoing it there. One other point I'd like to make is that we're eating out more than ever. And one of the techniques you'll see in slides to come, I encourage my patients to eat out no more than 1 meal a day. It's more the norm than the exception that people eat 3 meals away from home. And then finally, we're eating more fat and sugar than ever, and we have not pushed the dial on exercise. So there's a lot of opportunity here for us to make lifestyle change. And of course, the role of a behavioral interventionalist to help people execute that change. I will say how much weight do people need to lose if they're overweight? A successful weight loss change of roughly 10% of your body weight leads to substantial improvements in GERD symptoms. And I'll show you another study about that coming up here shortly. So I had the pleasure of working with Dr. Yalaplati and a few others on this TRIM study, which was a reflux improvement monitoring study at Northwestern. And the goal was to try to trigger something in the patient's chart to say if you had a BMI of 30 or greater and you had a diagnosis of GERD, could we funnel you to our health learning center where there are health librarians to help you make change? We developed menus and recipes and snack ideas, but the real key here was that we had them check in with a health educator intermittently over the year to make change. And what you can see is that there was a change in GERD-Q symptoms. And as we follow people out to a year, the people who continued to be enrolled in our program continued to see not only weight loss change, but symptom change in their GERD-Q. About a year ago, this paper was published that got lots of attention, and probably many of you had to field questions about being vegan. And the major piece of this study was a retrospective chart review that looked at a 90% vegan diet Mediterranean diet on controlling GERD symptoms. Independent of the study design, what I will say is we really don't know what people were eating before or after. We don't know what their change in BMI was, but people did get better on the diet. The authors speculate that this could be because of less proteolytic enzymes irritating the esophagus. But I would like to suggest that there's probably also some behavioral reasons why people lost weight and felt better. You can't really go to McDonald's and ask for a 90% vegan Mediterranean diet. So that genuinely means you're doing more meals at home. You have more control over what you're eating. There are multiple lifestyle factors there. From that study, several other studies were recently published. These are only 3 that I wanted to highlight, starting to get more at mechanism about how more plant-based foods could improve reflux. Whether we're talking about enzymes, more fiber that is promoting bowel laxity, there could be multiple mechanisms, but there's quite a bit more in this space about more plant-based fiber. So what should we recommend when you have a patient with persistent symptoms? I think there's probably different phenotypes. Your GERD patient who is normal or underweight is likely very different from your GERD patient that is normal to overweight. But I think the dietary guidelines are a wonderful anchor, and there's tons of free materials on the dietary guidelines website. One of the major recommendations is that we need to get Americans eating more plant-based proteins. I also love the plate approach, getting people to kind of visually split their plate in half and reduce the amount of starchy foods that they're eating. We also work on not having people feel like they have to be perfect eaters, but limiting the sugar and some of the high-fat, high-energy dense foods in their diet. The focus on total diet is key. For a long time, we singled out things like blueberries and beta-carotene and fiber, and what we found is that when we looked at these individual nutrients, as opposed to just regular food, we missed the point because foods have this nutrient matrix where they work together and they work off of each other to produce their beneficial effects. In general, the focus, whether it comes from you or a dietitian in your group, needs to be on helping people make better choices, whether that's at mealtime or at snack time. And it's also essential to give people specific strategies on how to split up their plate, eating on a schedule, some of the behavioral techniques that we use often. So in summary, I think that a standard healthy diet, while it may not be terribly sexy, is still very relevant. The idea of people to get to eat more at home, to cook more of their food versus dining out, and to learn to eat on a schedule still really matters. Recent papers published for cardiovascular disease and diabetes are looking at the powerful impact of diet quality. And what we really clearly see is that a good quality diet, it doesn't have to be perfect, but 80 to 90% of those core foods actually fueling our body, focus on fruits and vegetables, plant-based foods, healthy fats, that dietary pattern significantly protects us from other chronic diseases. We don't really need to push the individual elimination of refluxogenic foods like tomatoes and mint. Those things can certainly be integrated into your patient's diet, especially if people notify you that those are triggers, but we don't need to globally chop them out. And then finally, I think looking at what people eat really matters, but how people eat is easily the 50% of the puzzle as well. In summary there, think about your reflux patient who doesn't eat all day because they want to avoid symptoms, or your IBS patient that doesn't eat all day and then will come home and eat their largest meal at night. So sometimes the eating behavior discussion before we even get into what people are eating is an important opportunity for intervention as well. Thank you very much for your time.
Thank you, that's great. Next we have Dr. Vilche from Dietary Therapies for IBS.
Thanks so much, Lori. And we've talked a lot about how this field is changing rapidly, and I'd point out this afternoon's symposium is perhaps the best example. If you look at the speakers, only 2 out of the 6, including our chair, are actually physicians. It's interesting that we have a dietitian, a couple of behavioral therapists, one of the foremost GI psychologists chairing the session. So I'm going to talk about diet and its relevance to irritable bowel syndrome. And of course, we're going to talk about IBS, which is a symptom-based condition defined by the presence of abdominal pain and altered bowel habits. And remember that it is a symptom-based condition, so it's not one disease, it's many diseases, as we've talked about many times in this conference already. Recognize that at its core, IBS for the vast majority of patients is related to eating meals. So the vast majority of IBS patients associate either triggering of their symptoms or worsening of their symptoms with eating food. And of the different types of foods that patients consume, IBS patients consume, carbohydrates seem to be the most closely identified as culprit foods. There's also other recent data that supports this notion that functional GI symptoms and IBS specifically is associated with eating a meal. This is a paper that was just published in the Red Journal, you may or may not have seen, but it's an interesting analysis from the NHANES database that basically looked at a whole variety of different variables and their potential association with chronic diarrhea. And at the end of the day, amongst many dietary factors, the one that came out as potentially relevant to patients with chronic diarrhea is high dietary carbohydrate intake. So supporting this notion that carbohydrates may well be associated with functional GI symptoms in general. There are a variety of other factors that I'd encourage you to look at this interesting paper. Now, another paper just published in the Red Journal addressed this issue of ultra-processed foods. I don't know if you saw this, but ultra-processed foods are defined as industrial formulations usually made from substances derived from foods. That's a little scary sounding. Substances derived from foods. And additives using a multitude of sequences of processes to create the final product. So this is definitely not whole foods. But by the way, this is important because they looked at data from over 33,000 people who enrolled in this comprehensive dietary study, online dietary study. And they found that ultra-processed foods accounted for 16% of food consumed in weight, corresponding to 33% of a person's daily energy intake. And at the end of the day, if you go down to the last bullet, increased ultra-processed foods consumption was associated with a higher likelihood of suffering with irritable bowel syndrome. So certainly not absolute proof of cause and effect, but another bit of this jigsaw puzzle that is increasingly pointing towards food as an important variable in the illness experience for patients with IBS. Steve did a wonderful job of discussing how food may lead to symptoms in patients with IBS and other functional GI disorders. So I'm not going to spend a lot of time on this slide except to say that there are clearly direct effects and also secondary effects which can be exerted by food that can lead to alterations in the pathophysiology or alterations in variables that have been thought to be important in the pathogenesis of IBS. Think about osmotic effects, the chemical effects, the mechanical effects, effects on the neuroendocrine cells within the GI tract, prebiotic, probiotic, postbiotic effects related to food, as well as the byproducts of fermentation, the metabolome that Steve already alluded to, the effects on the microbiome, as well as bile acid concentrations. Altering the pH in the colon and the small bowel will change the concentrations of primary and secondary bile acids. And in aggregate, these things can work to variable degrees to affect motility, visceral sensation, dysbiosis, permeability, immune activation, all the things that we've been talking about as cardinal features relevant to the pathogenesis of IBS during the course of the last couple of days. So let's go through the evidence which might support a role for the use of diet therapies in patients with IBS. We're going to talk about gluten-free diets, elimination diets, and then finally finish up with low-FODMAP. So there is data now from several studies to suggest that a gluten-free diet may offer benefits in patients with IBS. Now, this is data from the first randomized controlled trial that evaluated a gluten-free diet in patients with IBS. We have to point out that these were IBS patients who thought they were sensitive to gluten, so this was not any IBS patient. But at the end of the day, in this selected population, restricting gluten, restricting or not providing either a muffin containing or not containing gluten, there was a reduction in symptom burden associated with the gluten-free muffins. And not only GI symptoms, but also fatigue and tiredness, which is a very interesting observation that's now been reported in several different studies with several different diets, is that these diet therapies not only make the GI symptoms better, but also potentially non-GI symptoms as well. A more recent study, an observational study, not an RCT, in 41 patients with IBS-D made a couple of interesting observations. First one is that almost 3/4 of these individuals that took a gluten-free diet for a period of 6 weeks experienced significant reductions in IBS symptom scale scores. And secondly, is that of the patients that responded, 72% said that they thought the diet was effective enough to where they were going to continue with it even after the completion of the trial. And it's important to recognize that we call this a gluten-free diet, and we, in some ways, we also have labeled these patients as suffering with non-celiac gluten sensitivity. But it's important to recognize that the gluten may or may not be the problem. The pathogenesis of symptoms related to the ingestion of wheat can certainly be attributed to the storage protein gluten in some patients. But it's important to recognize that wheat is also the most fertile source of dietary fructans in the Western diet as well. And fructans are an important component of the Low-FODMAP approach. So fructans, remember, are universally non-digested and non-absorbed by the human small intestine, and therefore will get to the colon and be available for fermentation by resident bacteria. And then finally, this notion of the nocebo effect is also very important. We all recognize the importance of the placebo effect, and the idea that if you believe something will make you better, it's more likely to make you better. The nocebo response is equally important, particularly as it pertains to potential food culprits. So this notion that if you believe that a food is going to make you symptomatic or worse in some way, that's more likely to do so, is almost certainly operative. In fact, many studies have now reported a robust nocebo response in patients who believe that they're sensitive to gluten. I would point out that if you need a resource to help explain this concept to patients, we created a TED-Ed animation called "What is Gluten?" You can get it on the TED-Ed website for free. It's actually now over 1 million views. The second thing next thing we're going to talk about is the elimination diets, and there's starting to be some additional data regarding elimination diets used in real world clinical practice that extend beyond just low FODMAP or gluten-free. So this is a study that was recently published by Ali and colleagues from Yale looking at leukocyte activation testing. You may or may not have heard of this, but there are a number of commercially available tests that claim to identify alterations in immune activation as a response to eating certain foods. This is one of them. There's also mediator release testing, or MRT testing, and there's also IgG-based food antigen testing that's currently in clinical trials. This study with leukocyte activation testing actually showed a benefit for elimination diets based upon the results of leukocyte activation testing compared to a sham diet, which was created not based on the actual results of leukocyte activation testing. So you can see benefits for both the IBS GIS, Global Symptom Assessment Scale, as well as the IBS SSS, Symptom Severity Scale. And it's interesting that if you look at the table on the right on the slide, that a number of the foods that most commonly were found to lead to leukocyte activation on this blood testing are also foods that contain FODMAPs. So it's, of course, impossible on the basis of this kind of study to determine whether it's FODMAP restriction or really related to leukocyte activation. But nonetheless, here is a small study that suggests that leukocyte activation testing may provide benefits in terms of identifying a diet effective for patients with IBS. And then finally, we'll finish up with a few comments on the low FODMAP diet. Of course, FODMAP is an acronym that stands for fermentable oligonucleotide, monosaccharides and polyols, and this encompasses a huge family of different types of short-chain carbohydrates that are very difficult or impossible for your small bowel to digest or absorb. And because of that, they get down to the colon, where they're available for fermentation, producing gas, which can lead to luminal distension, short-chain fatty acids, which create an osmotic load. But also remember that those short-chain fatty acids will also change the pH within the colon, with attendant effects on the microbiome, possible the effects on the microbiome potentially affecting permeability and immune activation, and also this idea, this notion that it might also have effects on bile acid concentrations. So a variety of mechanisms that extend beyond the simple notion of producing gas and short-chain fatty acids. This is a busy slide, but it's an amalgamation of data that's in press at the Red Journal right now from a systematic review and meta-analysis that we recently completed, looking at all the randomized controlled trials evaluating low-FODMAP diet in patients with IBS. And there are now 7 which actually fulfilled our entry criteria into this meta-analysis. A low-FODMAP diet was associated with reduced overall symptoms compared to controls. In fact, there was a 31% reduction in the likelihood of remaining symptomatic on the low-FODMAP diet compared to some other comparator. There were 3 randomized controlled trials that compared the low-FODMAP diet with rigorous control diet, so another active dietary intervention. These were the studies that had the least heterogeneity between the studies. They were also the studies that had the least magnitude of benefit. Not surprisingly, because again, these were studies that all compared to another active diet, not a placebo or sham diet. So not surprisingly, the magnitude is less there. The overall quality of the data was very low, as Lynn already reviewed for you in her recent talk. Although the low-FODMAP diet is now included in the ACG monograph that was just published a couple of weeks ago and is now considered to be an evidence-based treatment for patients with IBS. This is data from the US randomized controlled trial conducted by our center, showing that for the primary endpoint at 4 weeks of adequate relief, 52% responded to low FODMAP, 41% to modification of the NICE guidelines from the United Kingdom. So this is basically usual dietary recommendations for IBS. There was a therapeutic gain of 11%, which was not statistically significantly different. There was a trend towards, but not statistical significance. What there was significant different or benefit for were abdominal pain and bloating. And this is a very durable theme amongst all the studies, in fact, all 7 of the randomized controlled trials, except for 1. So the low FODMAP diet is most consistently actually a pain and bloating strategy, more so than a diarrhea strategy. It can be beneficial for diarrhea, but not as consistently as for pain and bloating. In addition, another analysis from the US randomized controlled trial, significant benefits for disease-specific quality of life. In fact, quite impressive improvements in quality of life compared to usual dietary recommendations. You can see very large deltas for social reaction, body image, dysphoria, and interference with activity. In fact, more than 2-fold increased likelihood of clinically meaningful improvement in disease-specific quality of life with low FODMAP compared to usual dietary recommendations. Remember that if you're going to use this diet, and we talked about low FODMAP a lot, but we haven't talked about this a lot during this meeting. It's just really important. If you're going to use low FODMAP, you really need to be going through this 3-step process, and we point this acronym ESP. So step 1 is elimination. And elimination should be viewed as not a treatment, but a diagnostic test. It's really a diagnostic test to determine whether somebody is sensitive to FODMAPs or not. If they are, then they go on to step 2, which is to determine sensitivities. Here we introduce foods that contain individual FODMAPs to determine a person's individual FODMAP sensitivities, which leads to phase 3, which is to use that information to personalize and liberalize the diet in the hopes of improving adherence and providing a more stable long-term solution for patients entering into this program. It's really important if the person does not respond to that elimination phase, which probably only needs to be 2 to 4 weeks, then they should go off of this diet and you should move on. 2 last studies I just want to mention quickly here. Comparative effectiveness trials, very interesting studies. One is from Monash University from Australia, another one from a different group that actually looks at hypnotherapy versus a low FODMAP diet, showing that both of these interventions actually led to statistically significant benefits in IBS symptoms compared to baseline, but no difference in the magnitude of benefit between interventions. So hypnotherapy and low FODMAP both improve symptoms, no difference in the magnitude of benefit. Similarly, a second random or comparative effectiveness trial compared yoga versus the low-FODMAP diet, both showing statistically significant benefits compared to baseline, no difference in the magnitude of benefit between low-FODMAP versus yoga in patients with IBS. So I think I don't have a summary slide here, so I'll just summarize very quickly by saying food is really an integral part to the illness experience of patients with IBS. We know that based on what patients tell us. We also know that based upon the scientific rationale that food can lead to a variety of changes in the GI tract relevant to the pathogenesis of IBS. There are now a number of evidence, or there's increasing evidence to support diet therapies for IBS. I think that the one that is evidence-based at the current time is low-FODMAP, but keep your ears to the ground. I think we're going to be seeing a lot more in this space, and we'll be learning about other interventions that will be also relevant and effective for patients with IBS. This is a website that's freely available that has animations, recipes, and can help patients to incorporate the low-FODMAP diet into their day-to-day lives. So thank you very much.
Next, I'd like to introduce Dr. Megan Rio from the University of Michigan, who will be speaking about behavioral strategies in clinical practice. And as she's starting, I'm actually going to turn the Facebook Live off if you're wondering where I'm going. I'll be right back.
Thank you, Lori. No disclosures for me. I'm a GI psychologist, and I am practicing at the University of Michigan, where I work with Dr. Shea.